In order to minimize this risk for children, we first need to learn the terminology, which includes the following terms: effective dose, or ED, volume CT dose index, or CTDI volume, dose length product, or DLP, and size specific dose estimate, or SSDE. What is effective dose? Effective dose, which is measured in millisieverts, is the sum of all the equivalent doses in specified body parts, taking into consideration the different radiosensitivities of each organ or tissue type. In other words, it represents the radiation risk. That is, the probability of cancer induction or other stochastic effects to the whole body. ED is helpful in controlling the exposure patients receive and comparing the risks of adverse effects of different procedures that use ionizing radiation. Calculating ED can be understood as occurring in 3 steps. First, the absorbed doses to the organs and tissues are determined, and they are measured in grays. Next, the absorbed doses are converted to equivalent doses. Remember, each organ or tissue type has a different level of radiosensitivity, and so the same radiation dose absorbed by muscle and by the thyroid do not represent the same radiation risks, for example. Equivalent doses are calculated by multiplying the absorbed dose by the appropriate sensitivity factor, or radiation weighting factor. Equivalent doses are calculated by multiplying the absorbed dose by the appropriate sensitivity factor or radiation weighting factor. Finally, effective dose is calculated by finding the sum of all equivalent doses using the proper tissue weighting factor. Calculating effective dose for children is complicated, and because of the conversion factors used to convert adult effective dose to pediatric effective dose, it is often very less accurate. The fundamental radiation dose parameters in CT is the computed tomography dose index, or CTDI. It is used to quantify patient exposure. It measures the radiation dose at the intended slice thickness, as well as that from the penumbra. CTDI is measured by the manufacturer and checked by the on-site physicist using an ionization chamber. The volume CTDI, a derivative of the CTDI, can be used to express the average dose delivered to a scan volume for a specific examination. The volume CT dose index measures the radiation dose output of a CT scanner and is a comparison metric for different types of CT scans and scanners. Reported in milligray, volume CTDI is a standardized measure based on manufacturer measurements for different protocols. This is determined with acrylic phantoms that are either 16 centimeters or 32 centimeters. Again, it is not the dose to the patient, but provides a sort of estimation. The size of the patient in comparison to the size of the phantom will impact the accuracy of the reported volume CTDI. The closer the patient size to the size of the phantom, the more accurate the estimation. The greater the difference of the size of the patient and the phantom, the greater the underestimation or overestimation of the dose. The volume CTDI is displayed on the scanner console before each exam and reported in the data page or DICOM structured report. It is crucial to check the planned volume CTDI before proceeding with the acquisition to ensure that the scanner output is adequate for the child. So, what is the dose length product, or DLP? Dose length product is the measure of the total radiation exposure for the whole series of images. It's related to the volume CTDI, but it factors in the entire length of the scan. It is reported in milligray per centimeters by the scanner itself and is essentially the product of the length of the irradiated scan volume multiplied by the volume CTDI. All scanners are required to report these two metrics, which, because they allow for the comparison of different protocols, are helpful in optimizing protocols in and between different institutions. Now remember, both volume CTDI and dose length product report the scanner output. And so, volume CTDI and dose length product both change as scanning parameters change, but neither takes into account the size of the patient, which is a relevant factor in calculating the dose a patient actually receives. Neither should be confused with patient dose. The American Association of Physicists in Medicine, or AAPM Task Group, in coordination with the International Commission on Radiation Units and Measurements, or the ICRU, and the Alliance for Radiation Safety in Pediatric Imaging's Image Gently campaign, developed conversion factors that take patient size into consideration and could be applied to volume CTDI to provide a better overall estimation of patient dose. Enter size-specific estimated dose, or SSDE. So, what is size-specific dose estimate? In their report, Size-Specific Dose Estimates, or SSDE, in pediatric and adult body CT scans, the American Association of Physicists Task Group 204 defined SSDE simply as a patient dose estimate which takes into consideration corrections based on the size of the patient, using linear dimensions measured on the patient or patient images. More specifically, it is based on the volume CTDI as reported by the scanner and the patient size. The report provides two tables of conversion factors to determine SSDE. One for use with volume CTDI reported with a 32 centimeter phantom, and one for a 16 centimeter phantom. In other words, these tables convert reported volume CTDI to a corresponding size-specific dose estimates, which is based on the patient's size effective diameter. A handful of studies have concluded that body weight can be used instead of diameter in calculating SSDE with no significant differences in results. Using the body weight method appears, however, to be less complicated and faster. It is important to understand here that regardless of the method used to calculate it, the SSDE is not the exact dose that the patient receives, since some of the factor values used to calculate SSDE tables, such as the length of scan, might differ from actual scan conditions. Instead, SSDE is an estimate of the dose received by the patient, represented by the average dose at the center of the volume scanned. It is a more accurate estimation than volume CTDI. Now that you understand the basic concepts of exposure and dose, let's discover how to optimize the image quality and dose when acquiring a pediatric CT. Here we have different guidelines that come into play with respect to the acquisition parameters, the morphology of the patient, patient centering, filtering, the influence of the tube voltage as well as the influence of the tube current, auto MA, the benefits of dose modulation, single slice and multi-slice CT scans, diagnostic reference levels, image reconstruction, and of course a summary of all of those. The radiation dose in CT scanning depends on the energy of the beam collimation, the MAS values, filtration, the scan pitch, iterative reconstruction, and lead shielding. As with radiography, the energy of the beam controls penetrability and scatter production. In CT, the KVP is usually kept in the range of 120 to 130. Two sets of collimators are used. One is positioned in front of the primary beam, or pre-patient. The other is positioned in front of the detector array, or post-patient. The MAS is varied in order to perform each scan. More MAS is used to scan larger volumes of tissue or compensate for thinner scan slices or tight collimation. Because CT is a computer-assisted technology, the effects of changes in MAS do not appear the same way as with film screen radiography. Instead, optimization in signal-to-noise is sought. Filtration serves two purposes: skin dose reduction and reduction in certain kinds of artifacts that result from the effects of beam hardening. The pitch is the way in which the continuous spiral of the scan is stretched out or compromised. The pitch is the way in which the continuous spiral of the scan is stretched out or compressed. It is defined as the ratio of the scan table increment, or BI, which stands for bed index, per 360 degrees of X-ray tube rotation to the slice thickness or slice width. When pitch ratio is higher, patient dose is reduced. Iterative reconstruction can be used to reduce dose levels while maintaining acceptable noise levels. And finally, shielding is generally not utilized in CT because the beam is so tightly collimated to the slice thickness. This table, shown here, provides a simple summary of the effects of changes in key parameters on radiation dose. For example, the X-ray beam energy, higher energy increases radiation dose. The tube current, higher tube current increases radiation dose. The gantry rotation, the faster the gantry rotates, causes a decrease in radiation dose. The section thickness or slice thickness, the thinner the collimation, it is linked with increased dose. That is because there are more slices necessary to cover the area of interest. The pitch, higher pitch decreases radiation dose. The distance of the X-ray tube to the CT ISO center, optimal patient placement decreases radiation dose, hence the importance of good patient positioning. And the scan length, lengthening the scan range, increases radiation dose. So let's talk about morphology of the patient. For the same acquisition parameters, dose values are inversely proportional to the patient size, explaining why equivalent doses are much more harmful in pediatrics than they are in the adult practice. Verifying that the center of the patient coincides with the center of the CT gantry is a significant part of the dose reduction strategies that is under the control of the CT technologists. A miscentering of 2 centimeters can produce as much as 25% unnecessary increase in patient dose. Here we can see the center, the isocenter, and then off-centering at different levels going up and at different levels going down. When we talk about filters or filtering, the flat filter attenuates low-energy X-rays that increase the dose to the patient without contributing to image production. This thin metal blade provides a narrow radiation spectrum, which is close to monochromatic. Here we can see a filter. The relationship between the beam energy and radiation dose is nonlinear. For example, changing the beam energy from 80 to 120 kV will change the CTDI in the head phantom from 14 to 26 milligray. Here's the milligray or CTDI scale. Here's the kVp scale. The relationship between the tube current and the radiation dose is linear, which means that increasing the tube current by 50% will increase the result by 50% higher dose. Here we go from 200 mA to 400 mA, which increases the patient dose from here to here. The influence of the tube current on the absorbed dose to the head and body phantoms. Again, the absorbed dose is linear with the tube current. This is an automatic dose response based on patient anatomy, or a scout view. Since the human body is not cylindrical, its contours and tissue densities must be taken into account. Automatic correction adjusts dose as a function of patient size and anterior to posterior and lateral directions. Here we can see how the MA changes up and down as the gantry circulates. Virtually all manufacturers use their own system for the automatic variation of MA as a function of patient morphology. The variation is a three-step process as we look at the benefits of dose modulation. The first step, determination of overall patient morphology. The same dose in MA used for the entire examination, but distributed according to the morphology type. The Z-axis, here we see the Z-axis. A suitable dose is delivered with each tube rotation, and the X and Y axis, here we have the X and the Y axis. The tube modulates dose at each rotation as a function of patient dissymmetry in the axial plane. If we compare single-slice acquisition to multi-slice computed tomography, we can deduce the following. In single-slice computed tomography, the entire beam, including the penumbra, is used to create the image. However, in multi-sliced computed tomography, if the penumbra is used, peripheral detectors would receive a beam of lower intensity than central detectors. This is avoided by increasing beam collimation. The penumbra thus reaches beyond active detectors that are thus all uniformly exposed. Diagnostic reference levels. To identify unusually higher radiation doses for common procedures, we use the diagnostic reference level as an investigative level which is based on standardized measurements of phantoms or patients at different clinical facilities. Achievable dose, or AD, is set approximately to the median of the study distribution, and it is used with DRL to optimize imaging processes by balancing image quality and patient dose. Diagnostic reference levels, or DRL, and achievable dose, or AD, provide target values, allowing a facility to compare its practice with other similar institutions. This table shows the DRL and DA for 2 pediatric CT scans based on phantom data. Take note, Other individual patients should not be compared with these values. Research that was done in 6 pediatric hospitals acquiring an abdomen pelvis CT for a 5-year-old patient with a lateral dimension of 20 centimeters showed a diagnostic reference level of 14 milligray and an achievable dose of 11 milligray. Note that the comparisons of the DRLs should only be made with patients of similar size. The Diagnostic Reference Range, or DRR, is a quality improvement tool that provides an estimated minimum radiation dose to the patient, below which reduced image quality may not reach diagnostic quality, and a higher estimated patient dose, above which the dose may be too high. An appropriate dose range for DRR was developed in a multi-center retrospective study analyzing the CT doses of 949 pediatric patients by examining image quality using a 5-point scale on a subset of exams. We can see on this table a summary of the results of this analysis. Experienced pediatric radiologists were confident when interpreting images of small patients with a body width of 14 centimeters, obtained with half the estimated dose used for an adult patient of 34 centimeters of body width, or 5.8 compared to 12 milligray based on the SSDE. This was done during abdominal and pelvic CT images with contrast. The subjective assessment of the cases of patients with a 14 centimeter width with a dose of 36 milligrays was considered diagnostic quality. SSDE-based DRRs and reference dose calculation methods allowed a substantial dose reduction while maintaining acceptable image quality. DRR takes into account the subjective image quality of the examination and provides an estimated minimum dose to the patient, below which accurate interpretation of an image may be hard, and a higher estimated dose above which the patient dose may be above what's necessary. Let's look at image reconstruction. The CT acquires X-ray projection data from multiple angles through an object to generate a tomographic rendition of its attenuation characteristics. Images are reconstructed from raw data using filtered back projection, or FBP, which operates on assumptions about the trade-off of scanner geometry between reconstruction speed and image noise. However, this is likely to provide inadequate image quality when dose levels are reduced. The iterative reconstruction, or IR, is an algorithmic method that uses statistical and geometric models to variably weigh image data in a process that can be iteratively resolved to independently reduce noise and preserve resolution and image quality compared to standard FBR. The iterative reconstruction is an algorithmic method that uses standard geometric models to variably weigh image data in a process that can be iteratively reconstructed to independently reduce noise and preserve resolution and image quality when compared to the standard FBP reconstruction. This improved signal-to-noise ratio can be swapped out for a lower tube current or voltage while preserving image quality and therefore reducing the patient dose. This technology has resulted in lower doses in the order of 20 to 40% to the standard FBP. When we look at these two axial images at the level of the liver, which were both reconstructed at 0.67 millimeter section thickness, we can notice the difference in the image noise, which has substantially decreased when using the iterative reconstruction as compared with the filtered back projection. So, in summary of this section, please note that the dose increases with the square of the kilovoltage. For example, when we reduce from 120 to 100 kVp, we can reduce the dose by 35%. Switching from slices of 2.5 thickness to 1.25 millimeter thickness will increase the dose by about 25%. The field of view is adapted to the morphotype of the child, but please note that the use of the field of view of 25 centimeters delivers a dose 5 to 10% higher than that for a field of view of 50 centimeters. MA values should be adapted to the morphotype of the patient. The child's weight or diameter and increasing the pitch from 1 to 2 will divide the dose by 2. And finally, the tube rotation time should be adapted to the required acquisition rate.